Hi everyone, in this lecture we're going to be talking about post-anesthesia recovery. This is chapter 14, and specifically we're going to talk predominantly about post-anesthesia care unit, or the PACU. So here's a picture of the PACU facility. You can see it kind of looks similar maybe to what you might have seen in an emergency room department, where it's very open. It allows the staff to attend to patients quickly and efficiently. When the patient leaves surgery, they're going to come into the PACU on their gurney, and there are these little stalls where they will rest until they wake up, and they'll be under the care of a registered nurse. The flow of the department is important, from where they enter the facility, where they get checked in, then they go to pre-op, then they go to the OR, then they're going to go to PACU. So the facility is designed for the efficiency of the flow of the surgical process. So after surgery, the post-anesthesia care unit is going to be where the patient goes to recover. Each patient is going to be individually monitored. All of their vitals are going to be monitored. Their medications are going to be within reach in the department, as well as supplies that the nurses need to take care of the patient while they are waking up. If there are patients that are going to stay in-house after they're recovered in the PACU, then they will be transported to the floor where they're going to be staying for the rest of their time at the hospital. If the patient is an ambulatory patient, then they will be discharged from the PACU itself. Now, there are quite a few procedures that occur in PACU that we're going to talk about, and the first one is admissions. So the patient comes into PACU. We kind of talked about the tail end of this in another chapter when we, talked about them transferring and transporting the patient into PACU. And so once they get there, immediately after surgery, they're going to make sure that they have their EKG on, their heart rate and their oxygen is going to be monitored, their blood pressure as well. They're also going to monitor the level of pain that the patient is having. So once they arrive, and typically the anesthesia care provider and the circulating nurse will take the patient to the PACU, and then that is where the handover or the handoff occurs. And so you'll be doing a project where you'll dig a little bit deeper into this near the end of the week. But the first thing that they're going to do is just provide a brief patient history. And the reason that they do that is so that the PACU nurse can have a good understanding of the patient's current medications, any existing pathology, and any of those things that are going to be relevant to their recovery in the PACU. They're going to determine the exact surgery that was performed. Sometimes we go in, we don't know exactly what we're going to do. That could be an exploratory laparotomy. Maybe while we're in there, we do a bowel resection, or we take out the spleen or the gallbladder, or whatever the case may be. That's going to be communicated. The length of time that anesthesia was delivered is also going to be communicated, as well as how much anesthetic and other various drugs were given intraoperatively. The estimated blood loss, or the EBL, is also going to be communicated. This is needed to determine if the patient might need to receive a transfusion in the PACU. The condition of the wound, if there's any drains or other devices that were placed inside the patient, or anything like that is going to be communicated. If there was any fluid that was drained out of that drainage device prior to the patient arriving, that's going to be discussed as well. The score, there's a special score called the ASA score, which is the American Society of Anesthesiologists score. And this tells the overall health status of the patient. So a score of 1 is going to be really awesome and amazing. And as the number gets to 2, 3, 4, that means that the patient on the extreme end could have comorbidities that could lead to death. Any surgical or medical complications that occurred during the surgery, if there was anything that we didn't suspect, or something that happened intraoperatively, a vessel ruptured, or something of the sort, that's going to be communicated as well. And then lastly, information about family members, because the PACU nurse is going to eventually go talk to the family once they get the patient settled and let them know about how long it'll be. And then at some point they'll invite 1 or maybe 2 of the family members can come back and visit with the patient when they're in PACU. So there's also going to be continuous assessment and care while the patient is in the PACU. And there's several things that the PACU nurse is going to be assessing. And the first thing is respirations. They're going to go ahead and listen to their lung sounds with a stethoscope. That's called auscultation. They're going to assess for any type of airway obstruction. If it was a general anesthetic, the patient had a tube in their throat, that endotracheal tube, and so just to make sure that the patient is breathing properly, they're going to assess the rate and rhythm of the respirations as well. They're going to assess perfusion. So a lot of times the way that they will do this is they want to see a fingernail or a toe, and they'll just give it a little bit of a squeeze so that the nail kind of blanches white, and then when they let go, they'll see if it gets pink quickly or slowly at the extremities, like I said, toes and fingers. So that can give them an idea if there is poor perfusion. They're going to look at the patient's skin and see the overall color of it. If it's really pink, then that's a sign of good perfusion. If it's more bluish or cyanotic, then that could be a sign of hypoxia, which is a low oxygen. They're going to monitor the heart rate. They're going to listen to the heart rate. And it's possible that they might also order arterial blood gases to look at the levels of gases in the blood as well. They're also going to assess their temperature. Remember, the operating room is a very cold environment. There's a risk of hypothermia when they come to PACU, and you'll hear the PACU nurses complain about this regularly, about patients coming back to PACU being really cold. So it's part of our responsibility to keep them as covered and exposed as little as possible during surgery so that they are not hypothermic when they go to the PACU. They're also going to poke around in their abdomen. They're going to press on their abdomen, feel if it's hard or distended. That could mean that there is fluid or blood or air in the abdomen. So they're, if they do think that something is of concern, then additional tests might be ordered. They're also going to use the stethoscope to just listen to their belly and see if they can hear any bowel sounds going on. That's a good sign. So there is one serious post-operative complication could be paralytic ileus. That means like the bowels aren't moving. Remember, to move contents along, the bowel uses peristalsis, that little squeezing, snaking-like action. And if that stops and isn't occurring, then that would be considered a paralytic situation. They're going to monitor their fluids as well as their electrolyte balance. The anesthesia care provider is going to indicate how much fluids the patient got intraoperatively. So they'll have an idea of that, but they want to make sure that they're giving the patient enough fluids so that they're not dehydrated and that they're maintaining that proper electrolyte balance. Neurological function is also going to be assessed, and they're going to use a scale called the Glasgow Coma Scale, and this is actually used out in the field with EMTs and paramedics as well, but this is going to assess the level of consciousness. When I see this, it kind of reminds me of when we talked about the APGAR scores for when a baby is born. So this is kind of a similar process of, assessing different things that are going on with the patient and assigning a number to it. If the patient is a 15, that's the best score that they can get. That's phenomenal. If it's 8 or less, we have a comatose patient. If it is 3 or less, then we have a totally unresponsive patient. So they're going to look at, can they open their eyes? And you will hear this in surgery a bazillion times. When anesthesia care provider is waking up the patient, they'll say, can you open your eyes for me? Right? And we'll see if the patient can open their eyes. So they'll say, can you lift your head and hold it for me? Right? Raise it up off the bed, sustained head lift. That's going to give them some clues that the patient is kind of gaining their strength back. So that's that motor response, right? They can respond when you ask them to. They can open their eyes when you ask them to. They're also going to assess verbal responses. Can they talk? Are they using appropriate words? Are they slurring words? Can they not think of what they need to say? Are they not responding at all? Are they just moaning and groaning while they're laying there? Okay. So this is a scale that they'll use. Other than that, like I said, they're going to assess pain. So is the patient really alert? Are they asleep? Can they be roused? Can they not be roused? How calm are they? Are they panicking? Are they moaning in pain? Are they moving around a lot? Are they not moving at all? What are their facial expressions? Is it a relaxed facial expression? Are they grimacing? Are they smiling? Some people are very happy and jovial when they're waking up from surgery, and other people wake up swinging, and then there's everything in between. As far as muscular response, again, they might say, can you squeeze my hand, or can you, I'm going to push against your foot, and can you pull it up, against my hand or something like that. So they're going to assess their muscle strength and are they able to move when they ask them to. Also, they're going to monitor urine output and also what the urine looks like. So if they have a catheter, they're going to make sure that they're making urine. If they had a catheter intraoperatively, that would be documented on the chart how much urine the patient made intraoperatively, and they're going to continue to document that. Wound assessment. They're going to check the wound periodically and make sure it's not bleeding profusely or weeping, or if there's a drain, that the drain isn't full of fluid that they need to empty out. If there is drainage, they're going to look at the color of that. If it's really bright red and it's filling up several times in a short amount of time, that could mean that the patient is actively bleeding. So they're going to check that, and they're also just going to make sure they assess their catheter or their tubings, or if their IV site and things like that. And lastly, we're going to talk about psychosocial care. So it's really scary waking up from surgery. If any of you have had anesthesia, and we've talked a little bit about it before, about how we kind of want to struggle to wake up, and we're in pain and we're disoriented. We might not remember where we are. And so part of the PACU nurse's job is just to provide emotional support for the patient. They're going to fall asleep, they're going to doze off, they're going to wake up, and they might forget where they are. Right? And so the PACU nurse is going to say, it's okay, you just finished with your surgery, you're just waking up, you did fine. And they might have to say that several times. And, if they're scared or cold or shaking or in pain, the PACU nurse is going to provide those supportive services and that supportive care to ensure that the patient feels safe and cared for. And lastly, like I mentioned, the PACU nurse will probably go out and talk with the family once the patient is kind of settled and they've got their baseline vitals and all of those fun things. If any of you have ever been waiting for someone that's having surgery and the nurse comes out and says, okay, somebody can come back, or 2 people can come back at a time, so that you can go back and visit. Or they might say, they're still really sleepy, I'll come out and get you when they're more awake. All right, so the PACU nurse is going to communicate with the family as well. There are several post-operative complications that can occur, and first and foremost at the top of the list is pain. And while pain is often an expectation post-op, not all patients respond to pain in the same way. Different patients have different pain tolerances. You might have one individual that has their knee replaced and they have a very high tolerance for pain, and you may have somebody else that is completely on the other end of the spectrum. It's also the PACU nurse has to think about that history of the patient. If the patient is, an individual that takes narcotics for pain or something like that, then it could take more pain medication to get their pain under control if they're having significant pain. And then culture can also play a role in it too. In some cultures, it's acceptable to acknowledge pain and cry out in pain, and in other cultures it's not. Or maybe in even different roles where it's almost expected, like it's a social norm that men are more stoic than women are. So that could also play a role as well. Oh my goodness. Okay, respirations. Respirations, again, an airway obstruction could be life-threatening. There could also be collapse of a lung. Another complication could be pulmonary embolism. Remember that the anesthetics that the anesthesia care provider is going to give intraoperatively is going to repress the respiratory system. It's going to inhibit breathing at some points, but it's going to slow respirations way down. And, the patient can be in a situation where they're so sleepy that they lose control of their tongue, and their tongue can actually fall back into the back of their pharynx, and it can cover over their airway, and that could cause an obstruction. There's risk of laryngospasm and bronchospasms, as well as aspiration. Remember, aspiration is when contents from the stomach comes up through the esophagus and gets breathed in through the trachea. And that could be a life-threatening situation for a patient, especially if we have an older patient that's not going to be able to ambulate well, and they're laying on their back for several days or long period of time. They could actually develop pneumonia because of that, and that could lead to a life-threatening situation for them. The cardiovascular system, hemorrhage is a big risk post-operatively. Some signs of that could be very pale skin. That we're gonna see low blood pressure, but we could see increased heart rate, right? So hypotension and tachycardia. There may be sweating also associated with it. And again, if they're hemorrhaging, like in the abdomen or, the abdomen, the tissue is going to feel very tight and distended. So that can be another sign as well. Hypothermia we talked about, but on the other end of the spectrum, there could also be malignant hyperthermia. So additional reasons why our patients can be so cold when they come to PACU isn't just because of the environment that's there, but if we're irrigating our patients' wounds with saline that is too cool, right? Also, the medications that anesthesia gives slows the metabolism, and so that could lead to cooling of the body as well. Anesthesia is extremely stressful on the body, and in a majority of cases, it's even more stressful on the body than the actual surgery that the patient is having, right? So that is also going to lead to an increased demand on body energy and then slow the immune response as well. As far as treatment for hypothermia, we have these heating blankets that we can use. And then we can also make sure that we're giving our patients warm IV fluids and we're irrigating wounds with warm saline as well. Malignant hyperthermia is typically triggered by some of the anesthetic agents that are given to achieve a general anesthetic. It's a rare condition, and it's one of the questions that the anesthesia care provider will ask the patient preoperatively if they've had a history of malignant hyperthermia, or if anybody in their family has had surgery and has experienced malignant hyperthermia. If that does happen, then they're going to use ice to pack like the armpits and the groin, the back of the neck. If it's intraoperative and we have the patient's abdomen open, we may lavage with cold water in the abdomen to bring their temperature down. And the medication that is used to treat malignant hyperthermia is called dantrolene. And dantrolene in the vial looks like an orange powder. I don't know if you guys are old enough to remember Tang, but Tang was like this powdered orange drink that you added water to, and dantrolene looks a lot like that in the bottle, and it'll have to be reconstituted with IV saline. The one experience that I had with malignant hyperthermia in the operating room was a young man. He was about 12 years old. He was a big boy, and he had appendicitis. And I was setting up at my back table. We had not started surgery yet. He was in there, and they were administering the general anesthetic, and the anesthesia care provider said, something's not right. He noticed that the end tidal carbon dioxide, the end tidal CO2, the blowout was continuing to increase as with each respiration, and O2 sats were dropping, and also temperature was increasing. So I broke scrub. I helped to reconstitute the dantrolene. I also ran to get ice packs for the patient. The appendicitis was emergent, but not urgent enough that we couldn't wait till the next day. So when something like that happens, that's the way that we respond. And we're going to kind of wait for the surgeon or the anesthesia care provider to tell us what our role is. And if they can discontinue the surgery, that's what they're going to do. From an anesthesia perspective, they're going to administer 100% oxygen. They're going to stop using those medications that are triggers for malignant hyperthermia. Nausea and vomiting is also probably one of the most common post-operative complications. I know that it is for me. Anesthesia does not agree with my body, and I end up having a really hard time post-operatively with nausea and vomiting, and I have a tendency to give them a heads up, like, hey, this is what happens to me, and then they try to treat that, preemptive treatment instead of waiting until the post-operative period. Alterations to consciousness can also occur from anesthetic agents and other medications that can cause unclear thinking or sleep deprivation. It can cause sensory impairment. Other risk factors are dehydration, those kinds of things. If we have patients that I think I gave the example before, that's of a patient that was having an elective procedure that said she didn't think she was going to wake up from surgery, and so I actually ended up canceling that procedure because the mind is a powerful thing. So it's important for us to understand kind of the backside of this, even though we're not typically in the PACU, but we're at the tail end, right, of surgery, right before they go to the PACU. And it's not, I wouldn't say it's a regular occurrence, but there have been a few times when the PACU nurses come to find somebody from surgery and they found me and they were like, did you empty the drain intraoperatively? We're having a lot of fluid, like what? They want to get more details or whatever. And so it's good for us to have an understanding of that. And then just a question, kind of food for thought for you guys, like, how does this impact us in other ways as surg techs? And if so, what role do we play? Is there something that we can do as surg techs to think forward, right, to that next step in the patient's surgical journey so that we can either make that transition for the patient and or for the healthcare provider during the recovery process. So something I'll let you kick around in your groups, and I look forward to hearing some of those discussions. Patient discharge criteria and unanticipated PACU outcomes. So discharge criteria, they're going to look at their physical status as well as their psychosocial status. They have to think about transport. Are they staying in? Are they going home? Do they have care at home? And about patient education. So as far as physiological criteria, there is a chart. It is not on page 312. I apologize. It's actually page 301 where you can find that chart. It's box 14.1, and it gives criteria for the vital signs, for ambulation, nausea and vomiting, and surgical bleeding. So another little score chart there called the Aldrete scale. Psychosocial status, some things that the PACU nurse will contend with is if the patient has transport home. They can't just call them an Uber and get them home. Okay, they have to have either special medical transport, or they have to have a family member or, a relative, whatever, an acquaintance, a friend, be able to take them home. So that's something that they're going to think about more on the front end, and not just at the last second, hopefully. Also, is home health care available if they need it? Hopefully that was set up beforehand as well. And then the home environment, is it suitable for the recovery of the patient? I know when my mom had her knee replaced, one of the questions that they asked is, does your house have stairs? And my mom's house does have stairs, and so they suggested, if at all possible, she stay somewhere for the first 2 weeks that did not have stairs. And so since my house doesn't have stairs, she was able to come and stay with me. So those are some questions that they might ask them. As far as general planning, if there are other situations where, like, the patient is going to be transferred to another facility, maybe an acute care facility or a long-term care facility or another hospital, whatever the case may be, there's in addition to a verbal handoff, there's typically a written one for the person that's going to be receiving that patient at another facility. So there would be another handoff, essentially. Home nursing care, again, many procedures that require days of hospitalization are now performed in day surgery. There's actually facilities that perform total knees and total hips, and then the patient stays for 23 hours and then they go home. So they don't even stay a full day. And there's numerous outpatient procedures now that are occurring. And then one thing that I think is so essential is patient education. And patient education should start in the office with the physician, teaching and training and educating the patient about what is going to happen, what they can expect, and the criteria that they need to follow and or meet post-operatively. When the patient is discharged from PACU, they're probably not going to be remembering things very well, even though the PACU nurse is going to go over the discharge instructions. They're probably going to ask that friend or family member to come and be witness while they go over the discharge instructions. And then they're also going to give them a written copy so that they have something to refer to when they get home. They can look it over. And they want those instructions to be written very simply, very directly, and in a layperson language. So what that means is they don't want it full of a bunch of medical jargon and terminology, like you just had a laparoscopic cholecystectomy and, blah, 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 because we understand that, but most of the general public doesn't. So we want it to be written in layman terms, very simple, easy to understand. Okay, they're also going to be educated about their prescriptions. If they're being sent home with prescriptions, or they have to stop and pick up prescriptions, if they need to take an antibiotic for so many days, and how they take their pain medication, and all of those kinds of things. Okay, as far as unanticipated outcomes, there might just be someone that just wants to get out of there, and they don't care if they're supposed to get out of there or not. And, that could be failure to meet discharge criteria. Now, we can't hold anyone against their will in the hospital or anywhere for that matter. However, if the patient is a harm to themselves or others, then that's a different story. We can't let them leave. But if a patient does leave against medical advice We call that AMA. They're going to be, it's going to be communicated to them that, hey, it's not safe for you to leave yet. And if they say, I don't care, I'm leaving anyways, then that's going to be a discharge AMA. Something else that can occur in the PACU is death. Death in the PACU can occur rapidly if we have a patient that is deteriorating. Surgery could be terminated intraoperatively and the patient taken to PACU, and resuscitative measures applied, and if that is unsuccessful, then death would be pronounced in the PACU. Okay. In those situations, they're going to have somebody there that's going to stay with the family and provide them emotional support, and also communicate to them other services that the hospital has that can offer them that extended support during that time. So this concludes our review of the post-anesthesia recovery. So I hope it helped to clarify things. Whatever muddy points you have, hash those out in your group and go ahead and share those in the discussion. I look forward to hearing those. And, if there was something that really jumped out at you today, after listening to this lecture, an aha moment or something like that, then I would love to hear about those things too. All right, thanks for listening.